Hi, everyone. Welcome to the lecture on estimation of costs for community mental health services. This is part of the mental health economics series. This lecture is based on this book, Mental Health Economics. Editor is Denise Rizalk, who is a psychiatrist and mental health economist. Published in 2017, chapters are written by mental health economists from around the world, and the purpose of the book is to reduce the knowledge gap between health economics and mental health disciplines. So the implementation of community-based mental health care in low and middle income countries has really just begun in the last 2 decades. Whereas in high income countries like the United States, this started a half a century ago, several decades. So it's been going on for quite some time. Now, before this reform in healthcare, mental health care, treatments were administered exclusively in psychiatric hospitals. And then over time, mental health budgets were reoriented from hospitals to community mental health services. Now, these services vary both in options for care and in how they are defined according to the local, social, and political context. These services often try to do a lot with very limited resources. Because services differ so much from one state or one country to another, it's really hard to compare mental health systems. So answering the question of whether costs for community mental health services are higher or lower than those for psychiatric hospitals depends on which services and which systems are being compared. When comparing models of care, it's important to look, or it's important to include cost analyses of all services provided in the community. So we're talking about outpatient care, emergency visits, housing, informal care, and other community-based programs. And so this lecture addresses the main methodological issues regarding the costing of community health services, focusing on outpatient care. Costing community health services is challenging because of the diversity of services, the complexity of these interventions, the lack of transparency and availability of cost data, and other constraints. Costing studies vary mainly in terms of goals, the perspective of the authors, the time horizon. In other words, how long are they looking at, 6 months versus 12 months, components of the costs, methods for estimating unit costs, measurement approaches, and sample characteristics. From a payer perspective, costing out mental health services is important for financial health management, planning service expansion, the comparison of health service consumption costs among different users, and also cost-saving ideas. From a public health perspective, costing out mental health services is important for to figure out how user profiles and different diagnoses impact costs, and also to determine how costs differ based on the modality of care, like hospital versus community services. And then finally, from a societal perspective, this kind of costing out is important for understanding the impact of mental health policies on productivity and opportunity costs. So there are really a lot of reasons to do these costing studies. One of the most important factors related to cost variations when comparing similar services is the estimation of units of costs. A study in Australia compared the unit costs for treatment per hour among 6 child and adolescent mental health services in different regions across Australia. And they found that the unit costs varied from $156 to $273. And similarly, the cost per episode also varied widely among the 6 services, from $338 to over $7,000, though the severity of mental health symptoms explained about just 6% of the cost variance. So wide discrepancy. So despite these data, user differences were not the most relevant factor in these cost variations. In other words, it's not really the patients or the differences between the patients that were explaining these discrepancies. Really, it's the service delivery factors that seem to be more relevant in this regard. And so that's important for better understanding costing. There are few studies on integrated care cost effectiveness. That's just where we are in the state of the literature. One study, though, in the United Kingdom evaluated costs of 260 mental health service users receiving different sets of integrated mental health services and other interventions in 4 centers in the north part of England. In this case, higher costs were associated with services targeting users with more severe symptoms, and lower costs were associated with integrated services. Another study in Spain compared the costs of services used by 81 subjects with schizophrenia disorders in 2 regions with different levels of care over a 3-year follow-up period. One with optimum services, and then another with minimum services. And in that study, only direct healthcare costs were considered. And the authors found that direct costs in the optimum services were 35% lower than those in the minimum services. So that supports the idea that these individuals with serious mental illness, they need a level of intensity that matches the level of need that they experience. The most common studies regarding cost effectiveness in mental health evaluate a set of interventions or specific programs rather than discrete services. One example is the Assertive Community Treatment Program, ACT, which has received a lot of attention. Improvement in mental disorder outcomes can last years. It can take years to see improvement. And in this regard, the balance between costs and effects can be unfavorable if better outcomes do not occur over a short period of time, like 3 months, 6 months. One interesting example is the TAPS project regarding the cost of patients with severe mental disorders. These patients were discharged from hospitals and placed in residential facilities. Now, the authors evaluated outcomes and costs during a 5-year follow-up period, and no relevant clinical changes occurred in terms of outcomes during the first year of follow-up. However, important improvements in social behavior were observed after 5 years, resulting in costs being reduced by 14%. Therefore, this is just another reason why these costing studies should really be measured looking at the long-term time horizon. After defining, well, let's talk about the steps in costing out mental health services. So the first thing is to define the goal of the costing study and the perspective that it takes. And then once that's done, you can begin collecting data for costs related to one service to identify all relevant, actually, I'm sorry, let me take a step back. So before you do any kind of data collection, you need to better understand the service of the program so that you can understand all the different relevant components of costs related to that service or program. So you need to know things like its structure, its resources, the process of delivering care, delivering interventions, all of that. So once you have a good understanding of that, then you can determine how costs will be measured. Is it going to be measured per day, per visit, per hour? And then which approach will be used to measure the cost? Is it going to be top-down or a bottom-up approach? Direct healthcare costs are more accurate if they're measured using a bottom-up approach. And that usually means that there's just a lot more detail about the service. So in that regard, data are collected taking into account variations among the individuals. You know a lot more about these individuals, and so you can account for those variations. The third step is to define the period of your data collection. Are you looking back? Is it retrospective? Or are you looking to the future? Is it prospective? Also, defining the data sources and the instruments that you're using. It's recommended to collect cost data over a long period of time. Data collection through inventories focuses on the consumption of services and resources by each individual, whereas a top-down approach uses the total data on the consumption of service resources, usually from like a large database or something that like a manager or an executive would have. So that's like the top-down approach. Usually, though, the recommendation is to do the bottom-up approach, where you have data about the consumption of services per individual. And then finally, the fourth step, or I'm sorry, there are two more steps. The fourth step is estimating the unit cost for each component of costs, or using some reference value when available. And then the final step is the cost analysis, combining consumption and unit costs, aggregating all costs, direct healthcare costs, direct and non-health costs, and capital costs. Marginal costs are used in the majority of economic evaluations when comparing interventions among individuals from the same service, or comparing costs of health system use among individuals with a specific profile or cost. So a lot of things can be done at this stage, and there's also a lot of preparation that needs to take place first. Okay, so in conclusion, costing community mental health services is challenging because the services are heterogeneous at all levels. And so for that reason, researchers should use caution when they're using a standard reference for unit costs, because that standard reference may not represent the real costs of a service when compared to some other reference, some other service. Also, human resources are the main component of costs in mental health care, and the accuracy when costing this component is crucial for achieving accurate estimates of service costs. Salaries and subsidies vary within the same professional category, significantly affecting service costs. Other factors affecting service costs are related to the geographical region where the service is located, the team size, and the interventions that are available. Although some studies have emphasized that individual factors related to service costs vary, other studies have shown a minimal effect of individual characteristics. Like I mentioned before, some research is showing that it's really not the individual that is making the difference in the cost. It's really the location, the service delivery. Also, a bottom-up approach is recommended. Like I mentioned, this is where you're looking at the per individual. You're not looking at like aggregated data. You're getting costs per individual. That requires a lot of information. Also, the long-term horizon is also recommended. So over a year, maybe up to 5 years or longer. It's crucial to measure costs in a broad manner, because costs can migrate from one service to another, and also from one patient or one family to another as well. So these are the things to consider when costing out community mental health services. And that's the end of the lecture. Thank you for watching.